field of medical retina, most of us been treating a lot of patients now using injections, seeing the patients on a frequent basis and on repeating the treatment. And we now have quite a few modalities that work in slightly different ways. And the difficult thing is to try and predict the response that patients may have to their treatment, and when it becomes time to either increase the intensity of what we're giving or maybe switching to something else. And so that gets into a field of biomarkers. How can we predict how a patient will respond? And there are, I think, two elements to this. The first is that there is the element of time, so that if we check back and look at how a patient is doing on the treatment regime that he's getting, from 1 month to the next, or from one visit to the next, we can very often predict a little bit in which direction it will go. And there are studies, for example, called I, that show that after you've given 3 injections of an anti-VEGF, you more or less know what a patient will do for the coming year in the field of diabetes. And it's more or less true also if you look at other fields. If you look at RVO, if you get a very good response at the very beginning, you know that these patients will respond, and that with probably 7 or 8 injections in the first year and 4 or 5 in the second, they will do quite well in the course of the initial few years and probably will be able to stop medication. Yet there are other patients where when we start the treatment, after we've treated them 2 or 3 times, we see very little response. And there we should start thinking about using combination medication or switching to something else. The primary way that I follow patients is by looking at vision, looking at the OCT, trying to judge in particular how the outer segments are doing. And by using OCTA today, we can look also at the deep vascular plexus, particularly in diabetes, because this is the one that gives us the information with regards to potential outcomes. In the end, what I'm also trying to say here is that it's not just one modality that helps us, but a combination. And herein, the standard fluorescein angiogram still plays an important role early on, and also in patients that don't seem to respond. Because the factor we very often do not think about is the inflammatory component that might be present and might require a completely different approach with the use of systemic medication or local medication to try to control the inflammation. My basic message to you is use multimodality to follow patients. Keep thinking about how the response is doing, particularly early on in the course, and be willing to switch early when necessary or intensify the treatment you're giving. And this is the best way to be able to offer our patients optimal vision and recovery in the shortest period of time.